My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
Hello, and welcome back to the first full episode of the Fix Podcast. Maybe this is the first one. Maybe the pilot counts. I'm not entirely sure. But either way, we are super stoked to bring to you some real content, not just talking about the show, but just being the show. But we just wanted to start things off between me and Soren because we have a lot of really cool things to share with you guys. And we were talking about what we wanted to talk about this evening. And Soren had just polished off a double arch that he posted on Instagram along with his timestamps. And I can assure you that they are for real. He's not lying. Of a double arch that he was able to do in about an hour and a half from first injection all the way to the last bit of records. Now, there's going to be a whole lot of things that we have to break down for this in terms of how he's doing his surgery, the armamentarium, how he's working with his assistants, his six-handed dentistry that was partially inspired by Dr. Matt Krieger, our friend over at aoxsurgery.com. We'll talk some more about him later on, hopefully have him on the show before too long here. But we're going to really break this down into the surgical techniques, the mindset behind everything, how to work on your speed, what workflow looks like, and exactly how Soren is doing these things. I'm doing it too. I just don't do it as well, Soren. So I'm hoping to learn a little bit too. But anyway, Dr. Soren Paape, welcome to your show.
Hey guys, how's it going? So excited to be back on here again. Man, Tyler, I'm just like pumped about this podcast. I'm sure you, the audience, can tell we're definitely spending a lot of time on our production value, and we're really excited for like posting some Instagram reels, getting you guys excited, getting like little tidbits of information, and then getting you excited for the upcoming episode. So that's our goal. Like I said, we're going to try to do bi-weekly episodes. This is our first full episode, our second technically episode-ish. But yep, today's going to be all about efficiency. But yeah, so talking about the case I did today, like I said on our last episode, I post every single case I do. Good, bad, ugly, complications that occur. I'll post them. You'll get to see them. Today, my case was a double arch. I think there was maybe like 24, 25 teeth. I'm going to see if you're watching on YouTube here. I'm going to see if I can post the pano right now so you can get an idea of that pano. And then I'll also post my post-op CT. So you can take a look at what the pano look like, what the post-op CT look like. On my Instagram, I did post some times. I think in the future, what I'm planning on doing is I take photos throughout all of my cases, and that's just for my personal records. Like I like having pictures of each surgery in case anybody down the line was like, this surgery wasn't up to par. I can say, yeah, it was. Show you the picture. But I might start posting like photos throughout the surgery with timestamps on them so you guys can get a feel of what it's looking like for like time-wise, like where I'm at in my surgeries. But yeah, today's surgery, we did first injection. Usually my patient shows up around 7:35, 7:40, and then CRNA brings it back, checks over all their medical history, and then he checks over all my medical history. I make sure that everything's all set, good to go, and then he puts him to sleep. Today we got started right around like 8:25 was my first injection. So after the injection, we'll go through all of the stuff, like all the efficiencies, how I work through everything. But my last stitch was at, I believe, 9:50. So it was like an hour, 25 minutes. And then it took about 20 minutes to do all my records. This is something that we'll talk about later in the episodes, like what Tyler and I's digital protocol is. We've transitioned a lot throughout doing these cases, what kind of works the best. And lately, prior, we were doing fiduciary markers. And I feel like a lot of people are doing fiduciary markers for their digital cases. I was having a lot of issues with just like maybe the scans weren't aligning or something, and I was having issues with patients, the bites being off when I got in there. Plus, it took me a while to get fiduciary markers in the retromolar pads. Sometimes it was like really quick. Other times, like their tissue would just be so thick back there, and sometimes my screws weren't long enough, or I couldn't engage good bone. A lot of times in that area where the retromolar pad is, there's like a thin cortical layer and then very medullary bone under it. So like sometimes you engage that cortical bone and then you just can't get stability with those fiduciary markers. So there's different opinions out there. Lately, what I've been doing is essentially a protocol where
can I stop you just for a second, just before we talk about the new protocol? So I do want to expound a little bit on some of the shortcomings of the fiduciary marker workflow, because that is like super common. It's what most people are doing when they first start doing digital. But I want to make sure everyone is on the same page about what that is. So when we're going digital, when you start a case, as opposed to an analog workflow where you already have prefabricated dentures that are ultimately going to be converted into an all-X prosthesis, a temporary one, you don't have anything like that. You don't have a prefabricated prosthesis. So what your lab has is the scans that you've already sent them along with some photos that they stitch together. And so what you need is you need something that's going to look the same and be in the same position in the beginning of the surgery as it is in the very end of the surgery when you're taking your postoperative records. And then that thing, whatever that fiduciary, is then going to relate to everything that you did to stitch everything together. The pre-op plan, the pre-op teeth, the pre-op plan, now the post-op surgery, and now the post-op plan that merges it all together. So you have one thing that's consistent. And on the uppers, this is fairly easy, somewhat consistent. I've had a few issues with it every now and then. Now I don't do it anymore, so I won't be getting any more issues. But you usually use palatal markers. So there's usually about a 7. Some of these screws are about 7 millimeters. Most of them are around 12 millimeters. You thread this through a printed marker. There's different scan bodies out there. The cheapest thing is just to have a little STL for a marker that has a hole in it that allows that screw to pass through. And then you print that, and then this can be printed in like a dye model resin, whatever. And then you're placing that in the patient. Up in the palate, usually 2. You can do 3 if you got space for it. And then the lower, you're putting the retromolar pads, just like Soren said. To start your surgery, you have to first place those, get them in place, and get them super, super solid so that even if you like tap on them with a mirror, they're not going anywhere. They need to stay in exactly the same place no matter what's happening throughout the surgery. Patients biting, moving around. You're using your instruments, that those things need to be really solid and engage really nice bone and cortical bone. Issues can come about when there's really thick tissue, just like Dr. Paape mentioned. When you have a retromolar pad that has really thick tissue, or even if you have a palate that has some flabby tissue, sometimes I see that from time to time. The screws aren't long enough, or they just don't engage very strong bone, and if those markers are moving, they're practically useless. On the lower, this is really tough, and you're having to do these scans before you even get started in your surgery. So you place these markers. This can take 15 minutes if you're being efficient, and then you have to actually take the scan, send it off to the lab, and then they then have to verify for you that stitches together with what they already had, that you didn't double scan something. If you do it and you double scan it, then you get started and it wasn't good, you're screwed. So a lot of things can come up with that. On the post-op end of things, you're then having to try to scan in a bloody field or take like an alginate impression and scan the alginate. Then there's a lot of work involved with the fiduciary workflow. Yes, you can use some existing teeth if there's some solid ones that you're not going to have issues working around during your surgery, but that does add a lot of extra steps. So Soren is going to talk a little bit about what we're doing now that helps circumvent that and makes digital a whole lot more intuitive and a lot more friendly to people that may be a little bit more accustomed to the analog workflow. Sorry, Soren.
No, absolutely. I'm glad that you stopped me there because I forget that not everybody's doing digital protocols.
Yeah.
And I think we actually talked about this last episode that sometimes we might, have to tail some things back because we're doing this every day. So it just seems natural for us.
For sure.
But we do want this to be a podcast for everyone.
Yes.
So first, let me talk about the 3 kind of main ways right now in digital dentistry that you can do your cases. Obviously, this isn't not digital, but analog is the first one, and that's what Tyler and I started with. We've done hundreds of arches analog before getting into the digital workflow. Number 2 is a digital workflow with fiduciary markers. Tyler just said, we're looking for a way to relate the pre-op to the post-op scans. When you take all the teeth out, a lot of things change. So effectively what they're doing is aligning those fiduciary markers so that the scans can align together and they have a way to merge them for pre-op and post-op. The second digital way is actually setting, and this is what Tyler and I do now, we set the VDO ourselves. What does that mean? It means using the patient's existing denture or printing a new denture for that patient. And what you're effectively doing is you're not putting any fiduciary markers in. You're doing your entire surgery, putting scan bodies in, and then you're taking a manual impression of the patient's arch on the top and bottom, and then setting them into a bite themselves. What this does is it creates, you're getting the location of those scan bodies, and you're aligning it to the VDO of that patient that's set by the denture, and then you scan the upper 360, the lower 360, and then the bite together. This allows the lab to merge those pre-op scans to that denture, and it aligns everything really well. And what I've found is I get way better bites. Also, I'm not dealing with, pitfalls with fiduciary markers, right? You're scanning in the mouth in a bloody field, or you're taking an impression, trying to get the fiduciary markers in the impression, and that's like just another thing that you need to get. So when you're doing an impression in the denture, effectively, it's less things that you're trying to get an impression of, and you can just scan the top, scan the bottom, scan the bite together, and then they can merge all that together. I like it a lot more. I find that it's much quicker. I find that my bites are a lot better. And lastly, there's one more thing I wanted to mention about it. But the pitfalls of this are you do need a denture ahead of time. If a patient has a denture existing, I will use their denture. But if not, then I will use a denture that's pre-designed.
Mm-hmm.
Did you have something, Tyler?
Yeah, no, I think one additional pro, I don't know if it's what you were thinking of, is it allows you, because you're using a denture and you're doing a wash in the mouth, you're able, and the lab is also able to physically see where those teeth are in relation to the face, in relation to the cant, and the relation of the dentures to each other. So let's say in the plan, things didn't really come together the way that we'd hoped they would, and maybe you're like really class 2 or class 3, you can take pictures and you can evaluate the case and say, hey guys, this didn't really line up that well, but I like where the uppers are. It's just a little bit too class 2. Can we bring those lower teeth forward? And that enables them to relate the soft tissue to the teeth in the position you captured, but also move from there as well. So it makes it much easier for them to adjust. In the fiduciary workflow, yeah, things may look like they've stitched together really well, but you're talking about these like little tiny markers across the entire mouth that you're hoping have stitched together well enough to where you're going to take this one little point, or maybe 2 to 3, and then you're going to have all these teeth that are trying to stitch from there in accordance with the soft tissue and all that. And you're hoping that does it in such a way that's going to coincide with the lower. And a lot of times you get these crazy open bites, you get things crossed up. With the denture workflow, even if you don't capture a wonderful bite, a lot of times the lab can actually move those teeth a little bit and get a more predictable bite that way as well, even if you're not able to get that really good capture.
Yeah, for sure. And then the last denture protocol for digital, and I don't want to get too far in the digital weeds because that's like a whole episode in itself. This is an efficiency one, but we're just giving you a quick recap so you can get an idea of this. But the last one is like segmenting CTs. So you can align pre-op CTs and post-op CTs, and in that protocol, you don't need fiduciary markers either. However, it takes like a special lab that knows how to do that. And it also takes a lot longer for the lab. So for me, I'm trying to deliver the teeth same day. You can do that with the CT protocol, but a lot of places that are doing alignment of pre-op and post-op CTs are doing next day deliveries. So it gives them a little more time for the lab.
Yeah, we actually did a really good podcast with Dave O'Dowling on the Full Arch podcast about a CT-driven workflow using those sort of hard relationship markers. And I think the new like SegMark workflow is similar to that in a way. Go over a lot if we did it on video and could do some screen share and stuff like that. So it's another reason this medium is going to make things like this a lot easier for people to understand. So I'm excited about that.
Yeah, absolutely.
Yeah.
But yeah, so I think best thing now is just to jump into what my protocol is. And Tyler, if you want to jump in at any point and talk about maybe where you do things differently, you're more than welcome to. But so let's talk about first, like every single step that I do. So first thing that I think is super important is making sure your team is set up and ready to go for the case. That means if in my office, I do everything 6-handed, and I think that doing things 6-handed makes it much nicer for your team to be passing instruments to you. You don't have to move. Basically, I sit there, I look in the mouth, and my goal is I don't look away from the mouth at all. My team is handing me instruments throughout the whole surgery, and I'm just focused on what I need to do next, and they know exactly what instrument I need next. They know what implant I'm placing. They know what their next step is supposed to be. Getting your team prepared and ready for the cases ahead of time, that might mean doing a couple days of just teaching your team, like going through what all the steps are with them, just so they can be ready to hand that off to you. Another thing I do to prepare for the case is the Wednesday before my surgeries of the following week, I prep every single case. Today is a Tuesday, tomorrow's a Wednesday. I will prepare every case for the following week. What does that mean exactly? It means bring up my CT, plan all the implants. I write all the implants down for my assistants. I write all the multi-units down for my assistants. I write any other thing that is needed. If they need, like when I was doing analog, it would be like tie cylinders, how many healing caps I need, just so they can then take those out, put them in a case pan, and have every single case ready for the week following. Why is that beneficial? 1, you're prepared for that case. 2, you never run into a situation where you're like, oh my God, we're out of 4x13s. What are we going to do? You want to be prepared for those cases, and you don't want a day where you're out of 4x13, so you have to use another implant just because you weren't prepared for that case. And I think that's definitely on the surgeon to have that ready to go. If you're like all of a sudden using a 5x13 implant on a patient who doesn't really need it, that's your fault. You didn't plan the case correctly. You weren't prepared. The team wasn't prepared. Definitely have these things ready to go ahead of time.
And I'll say too, just on the inventory note, I think the ritual of preparing all of your cases for the next week on the Wednesday is absolutely brilliant. But one thing that we talk about when we get into, the art of freehand surgery and not doing guided and having a really rigid plan, we do have plans. We do know, usually 80-90% confidence interval, what implant is going to go where. However, we do, in addition to setting out our pans or bagging up the cases, what I do, we also have a full stock of implants ready to go in case you do need to pivot, right? Like for a pterygoid or something like that, you might know that you usually place an 18 or a 20, but maybe just your angle's a little bit different and now you need a 24. You got some on the side as well. So after those cases get set aside, you're also making sure that you have a full stock of implants and every single size has the appropriate number associated with that so that you're always going to be ready. And it's good to actually have that in the operatory as well. So that you're like, okay, this one's not going to work. Let's swap out for this size. And then one of your assistants can go and grab that. It doesn't create an interruption. You're not having to leave the room and go get something else or say, oh, crap, I wasn't ready for that.
Yeah, absolutely. Part of what I was getting into was after they set aside all those case pans with the implants, we then do our implant order for the following week. So we're stocked. Great. And the reason that's beneficial is then you always have implant sizes ready to go. You're ready for the next week. But if, let's say, you get a last minute case, a patient comes in, consult, they're like, hey, I want to do this tomorrow. We got the implants for it. We're always prepared to always have a full stock of implants. And you can't always have a full stock unless you do your implant order after your prep for the week following. Yeah. So that's step one. Biggest thing, be prepared. Have your case ready. Make sure your assistants are ready for the case. Make sure you have all the implants, all the equipment. And then next, it's setting up for the case. I would really urge you guys to go on Matt Krieger's All on X or his website.
AOX Surgery. Yeah.
AOXsurgery.com. He's got pictures of his setup. He's got a great setup. He talks about every single instrument, what he uses every single instrument for. If I can, I'll see if I can post a picture here with like that setup and what he does. But I would just urge you to go on there because he explains everything really well. So making sure your team is set up. That means having implant motors ready. They should be checking the water on the implant motor. These are conversations that I've had to have with my assistants throughout this journey. Is let's say I go to get my implant ready and all of a sudden we're out of water already. And I'm like, guys, this stuff needs to be prepared ahead of time. Just check over everything. Think about it as if we're going through the full case and all this stuff should be, I have my implant motor setting set for 1 through 5. So we just step up as we go through the procedure and everything's prepared. Now, this isn't going to happen overnight. This is going to take a lot of cases to get this down with your team. But once you get it down, then I get asked on my Instagram all the time, like, there's no way that you did a double arch in an hour and a half. And it's once you have these things prepped, once you're ready to go, your team's ready, every single case should look the exact same every single time. And if you look at my Instagram and see my cases, it's hard to tell them apart. They're almost identical.
And I wanted to ask you this too, Soren. If someone were to watch you actually do the surgery, are you moving quickly? Like, do you move fast and all that?
I think it would be more of is like smooth. My team is very smooth. If you're in my op watching me, I don't think it looks like we're fast at all. It's just everybody's handing you things at like it's just like a musical, right?
Assembly
like
line.
Yeah, it's just I'm getting handed things when I need them. My team knows exactly what to hand me when, and it's just smooth, right? What's the quote? It's like smooth as slow, slow as smooth, and smooth as fast. That's what it is.
Yeah, I like speed up and slow down, or slow down and speed up.
Yeah. But effectively, what it's just saying, if everything's in the right place, everything's ready to go, you might not. That's the difference between rushing and just having efficiency with the case, and that's the goal. I'm not trying to rush. I'm not trying to go fast on the surgery, but I do want everything to be prepared and ready for the case, and then you'll see, holy cow, this is. I did an arch in an hour, and then all of a sudden I'll be like, I did an arch in 45 minutes, and you'll start to really speed up.
Yeah,
so,
I think if you want to see someone moving fast, you see someone that's like, maybe not their first case, but after like maybe 10, 15, 20 cases, they start trying to move fast.
Yes.
And they rush too much and they move on to something before they were done with the one thing. They're throwing instruments. It creates a mess. A slow surgeon when you see a messy operatory table, when everything's just all over the place, the assistants aren't putting them back where they belong. The doctor is physically like looking up and grabbing everything and then looking around for stuff. That's what fast looks like. Is actually very slow as far as the patient's concerned.
100%. And I think everybody goes through that a little bit, right?
Everyone does.
No, I'm sure when I first started seeing some of these people do these cases fast, my first intuition was oh, maybe I just need to move faster. And then, like you said, you're cutting your assistant off trying to grab instruments just to speed up. But then when you put them down, like you're not handing them back to the assistant and they're getting lost. And then all of a sudden you're looking for 5 minutes for your Molt 9 and you're like, what, like, where did that go? Because it's not in the place that it should be every time.
Yep.
But yeah, so that's like a pre-synapsis of what needs to happen before the surgery starts.
And can we talk just really quick about the six-handed part? So who is there, like a main assistant and then someone off to your side that's just like handing you other things? What are the roles? How do you explain that to them?
Yeah, absolutely. So my assistant to my left, she's my lead assistant, and she does all the suctioning. Okay, like her job is suctioning, reflection, making sure that the surgical field, I can visualize everything. And I'll talk about some tips as I go through my steps, but making sure that I can see everything, there's no blood, and everything is reflected correctly. That means using the right retractors throughout the case, knowing what retractors I want to use when. These things are really important, and that's what my lead assistant does. My lead assistant also will hand me off some instruments here and there if my second assistant is doing something else. If she's like loading an implant or something like that, and I need a Molt 9, she'll hand that to me. But her job is to keep the surgical field clean, keep the surgical field so I can visualize everything going on during the surgery.
Okay.
My other assistant, her job is to hand me everything exactly when I need it. So what is that? It means instruments, retractors. It means making sure my implant motor speed is set, making sure that she knows what implants I need when, and those are ready to go for the next case.
Okay.
Those are their responsibilities and job duties. And as I walk through my step-by-step surgical protocol, I'll walk through what they're doing.
Great. Thank you.
So let's get into it. This is probably what people want to hear, right? So first thing, let's start with, like I said, every case I take pictures. So before the case starts, upper lower photo of the patient with their teeth in, or if they're edentulous, what it looks like prior to the case starting. Then we use an O-ringer. I put the O-ringer in, and then we start our anesthesia protocol. For my anesthesia protocol, and actually this is something that I don't think a lot of doctors do, that I do every single time, but my assistant we have 2 carpules going. My assistant's loading the second carpule as I'm doing the first one. I do all my anesthesia the same way every single time. My patients are under general, so I get a little bit of fluctuation with this, but I do a lot of oral conscious cases too. And in general, this is how I do my anesthesia almost every time. It is on the upper, I do 3 carp septo, 2 carps marcaine. So that means a carpus septo on upper right quad, carpus septo upper left, carpus septo throughout the palate. And then I do a carp of marcaine across the whole buccal. And all of these are deep injections. I don't even touch, and this may be controversial, but this is what I learned. My oral surgeon told me, I don't touch a blue tip. Every single case is a yellow tip. So it's
Always
deep injection. And I feel like a lot of people, especially when they're starting, they don't do this. And like halfway through, the patient's hurting. And it's like, it's because you're not deep enough.
They're taking the blue tips and then they're bending them, and they're just
it's like barely getting in there. And it's if you're doing good cases, you should be reflecting everything up.
Yeah.
So, and you need to go deep with your injections in order to get that properly. But then marcaine across the buccal, marcaine across the palate. These are all just local infiltration, deep injections. And then for me, I'm going right to the bottom, getting everything numb down there too. For my lower, it's opposite. And this is what I tell my assistant so she knows. On the lower, it's 3 marcaine, 2 septo. So I do a block with marcaine on the right, a block with marcaine on the left. Then I do local infiltration with marcaine across the buccal and lingual. Then it's septo across the buccal, across the lingual of septo. Now, this is like a generalized anesthesia protocol. Yes, I'm hitting the PSA, I'm hitting the MSA, the ASA. These are all just me, deep injection throughout the buccal, and I'm just hitting that anatomy as I'm going. So that's all the septo, all the marcaine, and when I'm injecting, my assistant is then placing the next carpule into the syringe and getting the next one ready to go. So it's just like a handoff, right? I take it, she hands it off, I hand it back to her, next one, and I'm just going through so I do all my infiltrations like relatively quickly. So once the patient's all numbed up, then the next step is the reflection, right? So I have the O-ringer in. I I've had a lot of issues with the O-ringer coming out, and I've had a lot of issues with the O-ringer coming out throughout the case because I'm like moving things around. So I will suture the O-ringer to the patient's mouth. And the way I do that is I just do a suture. I do a suture through the lip on the top, and it's like a big mattress suture. So up the lip back through, tie it off, same thing on the bottom. So they're both sutured in on the top and bottom of the lip. So now patient's fully numb, O-ringer isn't going to move. Now we're ready to jump into it. So my assistant was handing me everything throughout that. She handed me the suture, and they know next, if there's teeth involved, my first step is large, straight, and this is, don't do every single thing I do to the T because everybody does things differently. Whatever elevator you like to use, grab that one. I prefer a large, straight elevator. So my assistant knows that, hands me that with my Minnesota, and I'm just elevating every single tooth. Now, I think I'm gonna go through this, and then at the end I'll talk about what I've been recently doing. But this is in general how I do most of my cases. I start with the top, and then I go to the bottom. I'm still able to do arch 45 minutes to an hour this way. However, lately I've been trying some other things that I'll talk about at the end. But this is my main protocol, so let's start with this. Large straight elevator. Elevate all the teeth on the top. Until they're mobile. I really shoot to get those teeth mobile. If the teeth aren't mobile, most likely you're picking up a handpiece down the line. My goal is to not pick up a handpiece at all to take these teeth out. Now, am I always able to do that? No. But the first step to doing that is getting the teeth mobile. So large straight across the whole arch. Next, if there's molars, my assistant knows right away. The only forceps I use for upper molars is a 150. Sure, you can use 88R, 88L, like there's a lot of different options. I use a 150 almost. So I grab the 150, take out the molars, right? If a molar breaks as you're going, don't sit there and start finagling with it. Just leave it, move on. Next, my assistant knows, once I get all the molars out, I hand her that back. And they're sitting there, right, they've got a gauze in one hand, and they're grabbing those teeth for me as I'm taking them out. Because it's like you're just grabbing them, handing them, grab hand, grab hand. Next, they know my next forcep is always an ash. I like an ash for my anterior teeth on the upper and lower. I can get really good leverage, and it's a rotational movement, right? You're grabbing and rotating. I'm rotating these teeth out. I'm not doing any buccolingual rotation back and forth at all. That's how you break teeth. If you rotate in a mesial distal direction, so if you think of an axis, it's like this. That's how I take out all my anterior teeth, and I almost never break off anterior teeth. The one caveat to that is those freaking like 25 millimeter canines, right? The crazy long canines. If I have a canine that I see and I know that if I grab it and that thing's not budging at all, I will come back to that. I'll grab everything else, come back to those canines. But in general, I am getting the canines out with that ash. So now we have all the teeth out. Let's say we have a couple roots in there.
I got a question.
Yeah, go ahead.
So a lot of people would say you got to flap first. Can we talk about why you like to extract first and why that works better for you?
Absolutely. Okay, so pros of flapping first. If you flap first, you get a good visualization of all the teeth. You can then take a surgical handpiece, cut and trough in between every single teeth, trough a line of exactly where your reduction is. You can measure from the incisal edge of the teeth, mark your reduction there, and then you can, like, as you're taking the teeth out, take that buccal plate with it, and it's less reduction down the line. I think that's awesome. I'm all aboard that train if that's what you like to do. For me, I find that a lot of times when I'm reflecting my flap, it's like sticking to the teeth. The keratinized tissue holds onto those teeth, and it takes me way longer to flap. That's my personal opinion on that, and that's probably the main pro of first, right?
Yeah.
You can trough, you can make your line, you can measure everything. Now, what are pros of teeth out first? You get such better visualization after you take those teeth out. You can see everything. And what I do is I will save a couple key teeth that I'll then go back, place in the sockets, and still do that measurement. So usually that means a premolar on the upper right, central incisor, premolar on the upper left. And I'll keep those 3 teeth. My assistant knows that. She'll set them aside. She'll mark what tooth that is. And then I'll get to flapping. Another reason I like taking teeth out first is you can really, like, if you know how much reduction you're doing, you can, and when you're doing your reflection, you can make your initial incision and kind of plan for where that reflection is going to go. And so that means like cutting off all the papillas. A lot of times if there's a lot of perio, you can cut where that perio is going to be. So I'll do my initial, that's the next step, right? So after I get all the teeth out, I'm getting that 15 blade. I use a 15 blade every time, and I'm flapping from the back of the tuberosity, because I'm doing a pterygoid every time that I can, from the back of the tuberosity all the way to the front, and I'm cutting chunks of tissue out that I think that I'm like later I won't need because of my reduction. So that means on the front, like cutting one side of the papillas and then the other side of the papillas. And then my next step, my assistant knows, is handing me the rongeur. And then I go through and I rongeur off that tissue that I've incised off. And then I should have my incision lines done. And I also do right at the maxillary process, usually where the first molar is, I'll do a releasing incision. And I love releasing incisions there. I don't do a midline release, but I do a release on both sides. After that, 15 blade goes to my assistant. She hands me a Molt 9. I always reflect my palatal first. I go to the right where the nasopalatine is, get my Molt 9 in there, reflect up, and then I scrape along the bone all the way to the tuberosity. And didn't get it at first, but now every time the whole thing just flaps like this. It's just like one motion flap. And then I do the right side. I've been working on getting good with my left hand and doing the fillet with my left hand. However, I still usually use my right, and I just will do like a rocking motion, and it's usually 3 rocks, and everything's flapped up.
Yeah. I do the 3 rocks, but I do both hands at the same time.
Oh, really?
So once I get in the front, I can take either 2 Minnesotas or like a Minnesota and a Molt, and I'll just rock back with both hands at the same time.
Yeah.
Whole thing's done.
Nice.
Yeah. I really like sliding along the palate, though. I think that's really cool, and that's what I do for the lingual flap on the lower.
Yeah, I do
I know
that.
I'm getting ahead of it, but I freaking love this. It's one of the most satisfying things in the whole surgery. I look forward to it the whole time.
And if you do the slide, usually a lot of periosteum doesn't get attached, and it's just like it looks so clean.
Yeah.
It's so nice.
Because if the periosteum won't come with it, it won't work.
Exactly.
Right? Like, so if it worked, it's full. It's a full thickness flap.
Yeah, 100%.
Yeah.
And then I do my distal releases. So I do distal release back behind the tuberosity. And then what I do is I take and I do the same way every time. I use the Molt 9, the big spoon, and I will like slowly peel off the keratinized tissue till I get to the midline. If you don't get the keratinized tissue peeled off first, then that's how you rip your flaps.
Yeah.
So I get all the keratinized tissue off, and then I grab my Minnesota, hold it down, and do gross reflection of all the periosteum. I'm telling you, every single time my flap probably takes me a total of 3 minutes. Like doing my initial incision and reflecting all the tissue back. I'm reflecting to the floor of the nose every single time. It's gone. If you reflect properly, you won't have problems with bleeding. The patients bleed from their periosteum if you're getting a lot of bleeding. And if the if the patient's like very perio-compromised, and you will get some bleeding.
Perio and
but in
Eliquis
general,
or something.
in general, if you do get all the periosteum off of that bone, you're going to have a nice clean flap with minimal bleeding.
Yeah.
My next step is rongeur. Go through, clean up everything, get as much bone reduction done as I can with the rongeur. And I'll do that by doing in between the teeth, right, the furcal bone. I'll snip that first, go through, snip all the furcal bones, and then I turn my rongeur to the side, and I'll do a gross cut of the buccal bone, gross cut of the lingual bone. Now, be careful here, because this is when you can break off buccal plates. So I do this cautiously, but that's the next step every single time. And then
make sure you like squeeze hard on the rongeur so you actually break the bone before you try to roll it off, or it'll take more with it.
Yes, it will take the buccal plate, and that happens all the time.
Ask me how I know.
Yeah, exactly. So after that, think about this, right? We're probably 10 minutes in, maybe, and we've got all the teeth out, flap reflected, and a gross amount of the alveoloplasty done. Next step, my assistant, and they're handing me these instruments. My assistant hands me my straight handpiece. I've got a coarse barrel Meisinger burr on that straight handpiece, and she has the handpiece set, 40,000 RPMs, and I'm ready to roll on my alveoloplasty. I grab the straight. My assistant has the palatal side reflected back with her Minnesota. I grab my Minnesota, and it's one clean all the way across, because if you have a good burr that is sharp. Like it should be cutting very well. Now let me go back before I jump into this quick. At this point, I just forgot this step. At this point, usually I'll grab the teeth, place them in the socket, mark where 15 millimeters is from the incisal edge of those teeth. So I have my line across and I know where I'm reducing to. But then I take that burr, reduce all the way straight line across I do the right side first. And then on the left side, I'll do, because I'm right-handed, I'll do like a motion like this. I'm just basically, for the people listening to the podcast, it's just on the right side, you can do one clean, but then on the left, it's like a couple strokes to get the bone off the left side. I then evaluate it. I look at the patient's eyes and I look at where the tragus line is, and I make sure that everything is like perfectly straight looking down from that. And then usually I'll go through and clean up a couple of areas that maybe like every once in a while you like look at it and you're like, oh, like I sloped a little bit buccal on the left side compared to the right. So I'll clean that all up. So then alveolo's done. Next, hand it off to my assistant. She does a quick clip, takes the straight off, puts my contour angle in with the pot ready to go. She changes the motor to 1200 RPMs, and then I'm ready to go for my osteotomies. I take a quick peek over at my plan. I'm like, okay, my implants are coming out. I already got my 15 millimeters reduction done. My implants are coming out second premolars on both sides, and they're coming out in between central and lateral for my two anteriors. So then I take my pilot. I do them all at once. So I do my upper right, I do my straights, my upper left. Those front four are done. Now this is something that's going to be a little bit controversial too. Patsy protocol, right? Patsy protocol believes in doing pterygoids first. I still do my front four first, just because I like getting my arch in and ready to go.
Secure the case.
Yeah, just to secure it. And then I know like where exits are going to be, because I don't always do pterygoids. If my initial is in a molar, I don't need to do a pterygoid. I don't always do them, but I would say probably 90% of my cases now I'm doing pterygoids on.
Yeah.